Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of M.B.B.S course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. The knowledge of the breast anatomy is essential for surgeons undertaking oncoplastic, aesthetic, or reconstructive breast surgery. This talk reviews the applied breast anatomy from various medical examinations perspective. The breast is a modified sweat gland. The female breast is situated on the thoracic wall between the second and sixth ribs and from the lateral border of the sternum to the anterior axillary line. However, a thin layer of mammary tissue extends beyond this limit, from the clavicle above to the seventh or eighth ribs below and from the midline to the edge of the latissimus dorsi posteriorly. This fact is important when we want to remove the whole breast during a mastectomy. The extension of the breast into the axilla is called a Spencer's tail, also known as axillary tail of a Spence or axillary breast. Posteriorly, it is related to the fascia of the pectoralis major, serratus anterior, abdominal external oblique, and the most cranial part of the rectus abdominis muscle. The male and female breasts are embryologically similar. Around the 5th to 6th week of gestation, the mammary glands start to form from two bands of ectoderm known as mammary ridges or milk lines. The milk lines disappear after a short time, but rarely the normal regression of milk lines fails, and in adult life, accessory breasts or polymastia or accessory nipples or polythelia develop along the milk line. At birth, the breasts are identical in males and females. The enlargement of the breasts occurs in response to maternal hormones that cross the placenta. The female breasts remain underdeveloped until puberty. At puberty, it enlarges in response to ovarian estrogen and progesterone, which initiate proliferation of the epithelial and connective tissue elements. However, the breasts do not develop completely until pregnancy. Amastia or absence of the breast is a rare anomaly. It results from an arrest in the mammary ridge development during the 6th fetal week. In Poland syndrome, there is hypoplasia or complete absence of the breast, costal cartilage, and rib defects, hypoplasia of the subcutaneous tissues of the chest wall, and brachysyndactyly. Iatrogenic breast hypoplasia may also result before puberty due to trauma, infection, or radiation therapy. Accessory nipples or polythelia occurs in less than 1% of infants. It may be associated with certain congenital conditions and anomalies such as urinary tract and cardiovascular anomalies. Supernumerary breast or polymastia occurs along the milk line. They most frequently lie between the normal nipple and the symphysis pubis. They are associated with certain syndromes such as Turner syndrome. Accessory axillary breast tissue is an uncommon condition and usually it is bilateral. It develops outside the normal breast area, most commonly in the axilla. From above downwards, the mature female breast extends from the level of the second or third rib to the inframammary fold at the sixth or seventh rib. Transversely, it extends from the lateral border of the sternum to the anterior axillary line. The posterior surface of the breast rests on the fascia of the pectoralis major, serratus anterior, and external oblique abdominal muscles, and the upper part of the rectus sheath. The female breast is composed of 15 to 20 lobes, each of which composed of several lobules. Lobules are the basic structural and functional unit of the mammary gland. Unlike females, males do not have lobules because there is no need for milk production by males. The number and size of the lobules is variable. There may be from 10 to more than 100 lobules, and maximum numbers are found in young women. Lobules empty into a lactiferous duct. There are 15 to 20 lactiferous ducts in each female breast. Lactiferous ducts are lined with contractile myoepithelial cells and have a terminal ampulla. The ampulla is a reservoir for milk or source of abnormal discharges. Cooper's suspensory ligaments are fibrous bands of connective tissue that travel through the breast, insert perpendicularly into the dermis, and provide structural support. They form hollow conical projections of fibrous tissue filled with breast tissue. In conditions like inflammatory breast cancer, the blockage of lymphatic ducts causes swelling of the breast. The skin remains tethered to the Cooper's ligament, leading to a dimpled appearance in breast cancer known as PUD orange. The nipple is situated in the fourth intercostal space. Clinical examination of the nipple is part of normal breast screening procedures. Orifices of the lactiferous ducts open at its apex. The nipple contains a smooth muscle fibers arranged concentrically and longitudinally, which make it an erectile structure pointing outwards. The areola around the nipple is rich in sweat glands and sebaceous glands. It contains involuntary muscle arranged concentrically and radially. The glands enlarge during pregnancy and lactation and then are called as tubercles of Montgomery. These secrete an oily fluid that lubricates the nipple during lactation and prevents the nipple areola complex from cracking. Notably, the areola is devoid of fat and hair. The erythema, erosion or swelling of the nipple areola complex and acquired inversion of the nipple point to the presence of some obvious or underlying benign or malignant breast conditions such as Paget's disease, which is a rare form of ductal carcinoma in situ. In patients presenting with a persistent unilateral nipple lesion, the clinician should collect a sample to exclude Paget's disease of the nipple. The retromammary bursa, also known as the retromammary space or retromammary fat pad, is a loose areolar tissue located between investing fascia of the breast and the pectoralis major muscle. This space allows the breast to move freely over the chest wall, providing mobility and flexibility. It is often utilized in breast surgeries such as implant placements because it is an avascular and aneural space. The axillary tail of a spens, also known as the axillary process or axillary breast, is an extension of breast tissue that extends into the axilla. It is palpable in some normal persons. In a few others, it can be seen premenstrually or during lactation. A well-developed axillary tail sometimes gives impression of a mass of enlarged lymph nodes or a lipoma. This is clinically significant because it contains breast tissue and lymph nodes, making it a potential site for unsuspected breast cancer development. The three principal tissue types in the mature breast are glandular epithelium, fibrous stroma, and adipose tissue. The predominant tissues in adolescence are epithelium and stroma. In postmenopausal period, the glandular tissues are largely replaced by adipose tissue. The glandular system of the breast is composed of branching lactiferous ducts organized in a radial pattern like an inverted tree. Each lactiferous duct is an independent system and there is no cross communication between them. The largest duct lies just under the nipple and successively smaller ducts in the periphery. The skin and the retromammary space are rich in lymphatic channels. Small ducts at the periphery enter the breast lobule, which is the milk-forming glandular unit of the breast. A ductogram of the individual lactiferous ducts can be obtained after injecting contrast material into a single duct system. The ductogram opacifies the entire duct tree from the areola to the lobules at the periphery. It also demonstrates the functional independence of each duct system. Each major duct branches progressively towards the periphery and ultimately ends in the terminal ductules or acini. The acini produce milk in the lactating breast and together with the efferent ductules form lobules. The lobule is a three-dimensional structure. The entire duct system is lined by epithelial cells surrounded by specialized myoepithelial cells. The myoepithelial cells can contract and propel milk formed in lobules towards the nipple. The loose connective tissue around the terminal ductules and acini contain a good number of lymphocytes and plasma cells. The dense interlobular stroma contains other ducts, blood vessels, and fat. Outside the epithelial layer, there is a continuous basement membrane containing laminin, type 4 collagen, and proteoglycans. This basement membrane layer serves as a boundary between in situ and invasive breast cancer. The ductal carcinoma in situ is labeled as invasive breast cancer once the malignant cells cross the basement membrane and invade the stroma. The invasion of the stroma exposes tumor cells to the lymphatics and blood vessels lying outside the ducts, and thus metastasis begins. The lymphatics of the breast drain mainly into the axillary and internal mammary lymph nodes. 85% of the breast lymph drains into the axillary nodes. There are 6 groups of axillary nodes. Lateral axillary nodes lie along the axillary vein. Anterior group of nodes lie along the lateral thoracic vessels. Posterior nodes lie along the subscapular vessels. Central nodes are embedded in the fat in the center of the axilla. Interpectoral nodes lie between the pectoralis major and minor muscles. And apical or subclavicular group of nodes lie above the level of the pectoralis minor tendon and receives lymph from all other groups. The apical nodes are continuous with the supraclavicular nodes and finally drain into the subclavian lymph trunk. The internal mammary or parasternal nodes lie around the internal mammary artery. They drain the posterior third of the breast. Some cross to the contralateral side and drain into the contralateral parasternal nodes. Through this route, breast cancer from one breast metastasizes to the other and becomes bilateral. There are abundant lymphatic channels in the breast parenchyma and dermis. A group of lymphatic channels collect under the nipple and areola and form sappi plexus. Lymph flows from the skin to the subareolar sappi plexus and then into the interlobular lymphatics of the breast parenchyma. The axillary lymph nodes are divided into 3 distinct anatomical levels according to their relationships with the pectoralis minor muscle. Level 2 nodes are located posterior as well as anterior to the pectoralis minor muscle and posterior to the pectoralis major and include the subclavicular nodes. Nodes located posterior to the pectoralis major are called rotor nodes or interpectoral nodes. Level 3 nodes are located above and medial to the pectoralis minor and include the apical nodes. Nerves relevant to breast surgery or breast trauma are long thoracic nerve, also known as external respiratory nerve of Bell, thoracodorsal nerve, medial pectoral nerve, pectoral neurovascular bundle, and intercostobrachial nerves. The long thoracic nerve is also known as the external respiratory nerve of Bell. It runs downwards along the upper medial chest wall. It arises from the 5th, 6th, and 7th cervical nerve roots and innervates the serratus anterior muscle. The serratus anterior muscle fixes the scapula to the chest wall during adduction of the shoulder and extension of the arm. The division of the nerve of Bell may result in winged scapular deformity, hence the long thoracic nerve is preserved during axillary surgery. The thoracodorsal nerve innervates latissimus dorsi muscle. It originates from the posterior cord of the brachial plexus. It receives fibers from the C6, C7 and C8 spinal nerves. The thoracodorsal nerve is important in breast reconstruction surgery, especially when using the latissimus dorsi muscle flap. The thoracodorsal nerve and vessels should be preserved during axillary lymph node dissection. The medial pectoral nerve originates from the medial cord of the brachial plexus. It innervates the pectoralis major muscle and lies within the pectoral neurovascular bundle around the lateral border of the pectoralis minor muscle. The pectoral neurovascular bundle is a useful surgical landmark. It indicates the position of the axillary vein, which is just superior and posterior to the bundle. This neurovascular bundle should be preserved during axillary lymphadenectomy. The intercostobrachial nerve is formed by the merging of the lateral cutaneous branch of the second intercostal nerve with the medial cutaneous nerve of the arm. This nerve is sensory for the medial surface of the upper arm and skin of the chest wall along the posterior margin of the axilla. Division of these nerves results in skin anesthesia in these areas as well as chronic pain syndromes in a small number of patients. And this possibility should be explained to the patients before axillary dissection. Lymphatics also run along the intercostal brachial nerves, and sacrificing these nerves with their associated lymphatics may lead to lymphedema of the chest wall. Sensation of the nipple is derived from the fourth intercostal nerve.